So I thought a little bit about what to talk about today, and as you heard, I am a researcher, and it was tempting to me to do a talk today that was really focused on research results, just presenting lots and lots of data, one number after another. And I will get to that in a moment. But I really want to spend some time, in addition, talking about the process that led to this data. So I'll tell you about a research network that we've created, and I'll tell you about some of the research that we've done, and I'll try to mix those two together, really as a way of telling a story behind the data that I'll describe, some of the research studies that we've done, the process of putting this research network together. And I'm doing that very, very strategically because I think in some ways, in many ways, palliative care in the United States is, as you can imagine, decades behind what it is in the UK. But in some ways, or at least in some areas, we seem to have leapfrogged ahead. And it seems to me that at least in the area of data, there are pockets. I can't say the United States does data very well related to end-of-life care, but there are pockets and there are some success stories that might have something to share. So before I begin, I'll be talking, as you'll see in a moment, about a relationship that I developed with a software company. A software company that makes software for hospices, electronic medical records. And I'll be talking about some of our work in pulling data from those electronic medical records. So I just want to say up front that I have no financial relationship with that software company, that I've worked with them as a research partner, but I'm not employed by them and I'm not paid by them. I won't spend a lot of time talking about that now, but those of you who are in partnerships like this or considering developing them, I would love to talk to you offline about some of the advantages of working with a commercial entity on research, some of the advantages, some of the disadvantages, and thinking through how to manage those. Because this is one solution, just not to have any financial relationship at all, but it's certainly not the only one. So here's where I'd like to go. I'll tell you a little bit about why I think we need a better evidence base to guide hospice care. And along the way, I'll try to tell you a little bit about hospice care in the United States because I realize it's been brought to my attention repeatedly over the last 15 years or so that your system is a little bit different than ours. I'll tell you about our Choice Research Network. I'll tell you a little bit about ongoing research, but I'll really focus on one problem in particular as a way of kind of focusing our discussion on one area and one project, rather than trying to cover the waterfront and tell you about all the projects we've done. And then I'll wrap up by telling you about some of our goals, which really is to build a learning healthcare system that's not just quality improvement, not just research, not just operations, but which includes all of those. Some of you may recognize this name and this picture. Primo Levi was a Holocaust survivor, a chemist, and also a writer. He tells a great story right after World War II of going to work in a paint factory. And he describes his excitement and his enthusiasm in going to work in this paint factory because although he was a trained chemist, he didn't know anything about paint making. And this was really exciting to him, who's an educated guy, very smart, very curious. He thought he would use his degree, put it to work, and learn about the science of paint making. This was kind of an education for him. But he was really disappointed to learn after 2 or 3 or 4 days on the job that every time he asked why something was done this way or that way, the answer he would get is, well, that's just the way we do it. Or that's the way we've always done it. We don't really know why we do things this way. It just is. So don't ask questions and make the paint the way we're supposed to. So he quit because that wasn't meeting his idea of fulfilling his curiosity and learning and discovering. And I've become convinced over the last couple of years that hospice in the United States, and I think to a large degree, a lot of what we do in terms of palliative care in the United States, at least, and maybe in the UK too, but I don't want to put you in that mix unless you want to be, is guided by that same principle. That's the way we always do things. Just to use one example, we were talking just a few minutes ago about the use of intravenous opioids for patients at home. And I won't name names, but the person I was talking to, who shall remain nameless, said, well, we don't use IV opioids at home. Despite the fact, or you don't use IV opioids at home, and we do. despite the fact there's actually pretty good evidence, I think, much of it from the UK, that subcutaneous opioids work just as well. But why do we use IV opioids at home? Because that's the way we do it, and that's the way we've always done it. So this very much is the culture of hospice care and a lot of palliative care in the United States. We do it because that's the way we've always done it. So let me kick this off with a patient story. I'm a physician, and I wear a lot of hats. I'm a physician, I'm a leader in our health system, I have a chief medical officer role. As you heard, I'm a writer, but I'm a physician first and foremost, and I tend to think in terms of patient stories. So this is a 54-year-old man who was admitted to our home hospice program with metastatic colon cancer. This is a guy I met about a year ago. Had moderate pain on admission, for which he was taking just over-the-counter acetaminophen, paracetamol. His wife, became clear, was overwhelmed with caregiving, really wanted to learn about resources for caregiver support. That was what was important to her. But as I heard about his story, what I heard from both the nurse and the social worker who followed up later was that this patient really appeared withdrawn during most of those initial visits. Would fill in to answer a few questions about his pain management, but really let her do all the talking. So at our interdisciplinary team, just a word of background, so hospice in the United States, when we talk about hospice in the United States, we talk about hospice holistically, meaning a hospice that provides care in any number of settings. So hospice care is provided either at home or in a nursing home or in an inpatient unit. One hospice would provide care in all those settings, and when we talk about hospice care, we talk about care that's provided in all those settings. And so when patients are admitted to hospice, their patient care, the case care plan is discussed by the hospice team that includes a physician, nurse, chaplain, social worker, representative of the home health aide, and volunteer. So at one of these meetings, we had other medical students and residents, registrars there too, and so we were talking about his care and what his care plans should be. And I won't read these, but these are some of the questions that came up. And one of our enterprising medical students started doing some research online to begin to answer some of these questions. And what she said was that she kept feeding us results throughout the meeting. And one thing she said was that although there are answers to these questions in various populations, there really weren't good answers that she could find for a hospice patient in the United States. The one other thing to know about hospice in the United States is people use hospice very, very late. So our median length of stay in hospice in the US is about 18 days, which is gradually decreasing. And about a third of patients are admitted in the last week of life. So she was able to find some studies, but they were in patients with cancer followed for a period of sometimes months or years, or patients with dementia living in a nursing home, but she wasn't able to find answers to these questions for our hospice patient population, which is very sick, very near the end of life. So take that with a grain of salt. That's not a thorough, structured literature review, but she was really amazed that she was looking for studies and wasn't able to find anything. And that's really not surprising. I told you a little bit about length of stay in hospice. It's really, really hard to do research in a hospice population. It's really, really hard to do research in a hospice population in the United States that requires primary data collection. I mean, just think about the logistics of collecting data from patients who are enrolling in hospice. You're meeting for the first time. Half of them will die in the next 17 days. A third will die in the next week, and 10% will die in the next 24 hours. Just based on that alone, it's really, really hard to collect data. There are also ethical concerns. It's very difficult, often depending on where you are in the US, to get ethical approval to approach those patients or their families. And in general, those sorts of studies are expensive because it's not like you can park one research assistant in an outpatient clinic and do interviews. You need to send people out to patients' homes where they would prefer to stay. And short lengths of stay again, first, last, and always. That's one of the biggest challenges that we face. So it was partly due to patients like JR and their stories and a lack of data, and partly due to those sorts of challenges that led us in this case was me, other colleagues I'll introduce you to later, people like Laura Hansen, Joan Tino, Elizabeth Brown, to begin thinking about how we could use electronic medical record data to answer some research questions. And the logic is either very, very complex and worthy of an entire day seminar, or it's really simple. And I'll give you the simple argument, which is electronic medical record systems have a lot of data. I mean, a lot. Everything that you could collect about a patient, from vital signs to demographics to pain scores, to long descriptions of anticipatory grief needs of children. All of that gets put in electronic medical records for those hospices that use an electronic medical record. Not all of them. Right now in the US, my guess is probably about 35% of hospices use electronic medical record systems, rough guess. Those hospices tend to be bigger, so that's probably like 40 or 45% of patients. So not all hospice patients, not all hospices, but a lot. So we began to approach makers of hospice software, basically companies that produce electronic medical record software. And we finally found one called Suncoast Solutions, which is based in Florida, that understood the sales pitch I gave them about JR's story. They understood the Primo Levi story. They understood that we really need to do more as a hospice community to develop research. So I partnered with Suncoast Solutions, and the next step then was to start talking with hospice chief executive officers to get them thinking about whether they'd be willing to contribute their data to this data set. And this is what I heard from them. And this is, in a sense, maybe the most important slide I'll show you, at least the most important slide in terms of the background story of doing some of this research. Because this is what the CEOs of these hospices, the people who run these hospices, this is what they were telling us would lead them to contribute their data to a research network. This is what would induce them to tell the people who work for them, yes, this is really important, prioritize it. If these researchers have questions, make sure you answer them. If they ask you for data, make sure you get them those data. And this is the rationale that's important to them. It's not necessarily the rationale that's important to frontline providers, to clinicians, doctors, nurses, patients, families, to be a little bit crass, but that's what's important to the people who hold the purse strings of these hospices. And of those, it was really the last one that we heard by far and away the most, which is the most important to these CEOs. We're happy, they would say, to contribute data for research purposes, but we really want to know how, when we give you our data, how will this help us? How will we get our data back or other hospices' data back? How will we get benchmarks or results that will help us? So it was pretty clear after we did a series of 15 or 20 of these interviews that if we were to build a research network that was going to extract data from electronic medical records, if we were going to get data that would require hospices to contribute data to us, we would need to make sure that we were able to feed those results back to the CEOs, which is not, by the way many of us think in terms of research, right? I mean, we think about doing a study, we think about publishing, we think about disseminating the results to the community who helped us with those projects, but we don't really think, or at least I didn't think, about that sort of real-time feedback of we do these studies, we look at these data, and we feed these results back to a hospice, not next year, but next week. And that was really the mission behind Choice, to figure out what safe and effective hospice care looks like, and then to feed those results back to the people who could do something about that. Again, not next year, but next week. And so that's what we've been working on developing. And the story I'm telling you really has unfolded over the last 18 to 24 months, basically over the last 2 years. So it's still very, very early in its days. But we've constructed this as a community academic business partnership with Suncoast Solutions being our IT partner, the University of Pennsylvania, where I work, being the academic partner with other organizations like Duke, Brown University, University of North Carolina, and a few others. But probably the most important point on the slide is this one, that we've really tried to make this lean and sustainable. We've tried to build this into operations so that we're not relying on grant funding. We were fortunate, as I mentioned earlier, to get grant funding to get us started, but probably in the next, unless we really get lucky with grants we've submitted, in the next probably 8 to 9 months, our grant funding will disappear. But I think this will keep going because we've built this on operations, and it's important enough to the hospices that are participating to begin to pick up the tab for it. And I think, I don't know what the funding climate is like here, but certainly the funding climate for research in general and palliative care research in the United States is getting is getting tough. But the value proposition for these hospices participating in this research network, contributing their data, really is the data that they get back. Which is not to say that they're not altruistic. It's not to say that they're not interested in improving the science of hospice and palliative care. I think they are. But they also want to see results fed back to them in a way that's useful and meaningful. So I've talked in general terms. Let me switch gears a little bit and give you a sense of how this works and what this looks like. The short summary, and I won't walk you through all of this, but I'll sort of give you a 30,000-foot level of view of what this looks like. In general, we pull individual data sets from the hospices in the network. And I'll get to this in a second. Right now, we've got, in the pilot phase, we had 14 hospices. That's, as I'll show you in a minute, about 160,000 patients. We have an additional 50 hospices, 55, that are signed on, which we'll be putting on in the next 6 months or so. So for each one of those hospices that comes on board, we identify those data elements that are defined a priori as being important. We pull those data from each hospice, which is about as time-consuming as it sounds. Partly because it's repetitive polls from each of these hospices, but really the reason, really the reason is because although this is an electronic medical record system, although you'd think that Hospice A's data would look like Hospice B's data, there's enough customization that happens so that we really need to go back and check every single hospice that we added. To give you one example, we found that one series of hospices that we pulled initially, the use of a Foley urinary catheter was about 3 or 4%. So not huge, but not zero. We pulled data from a couple of other hospices and found that they weren't using Foley catheters at all. So we were really interested in that as an example of variation in practice. It turned out, though, when we dug into it a little bit more, that the other hospices actually did use Foley catheters. They were just storing those data elements in a different place. So we pulled from those fields, got nothing, initially assumed that there was no Foley catheter use, but it turned out that their use was on par with that of others. So there really is a lot of work in getting some of these data out. The good news is, though, that assuming there's no other customization going on after you do that initial pull, we get these hospices locked in and we figure out where they are. Sort of like we get a fix on where the data are in this hospice or that hospice, and we could at least put that set of data to bed and then work on the next one. This is partly an aspirational slide in the sense that some of these elements we can get reliably. We can get a lot of clinical data. We know who's on opioids. We know which opioids they're on. We know where they are, where they're admitted, where they spend time. We know a lot about visits, which patients get visits from which providers, when, how long those visits last, and so on. Some of these others, quality indicators, that was a goal and it still is. I'm not really sure what the optimal quality indicators for hospice are. I'm happy to talk about this offline later over drinks, but it turns out to be very, very difficult to get a bunch of hospices and hospice providers with strong opinions to agree on what sort of quality measures they want to be held accountable for. We're making progress, but we're not there yet. And the family evaluation of hospice care data, many of our hospices, I think all of them, use this survey. It's a survey that was developed by Joan Tino at Brown. It's administered to families about 6 weeks after patients die. We have those data only for 3 hospices. It turns out to be really, really difficult to link those data with the other data that we have. So the 2 examples in the end are aspirational. The focus really so far of our work has been on the elements in the middle. Things like demographic data, visits, which I described to you, pain data, site of care, as well as some other elements like where patients prefer to spend their time. So we take those data, we merge them together into one file. We extract any identifiable information. So any field, we have algorithms we go through and look for things that look like names. We extract those fields, other identifiers, to develop what in the United States we call a limited data set, which gives us more flexibility in terms of what we can do with those data so we don't have names or social security numbers. We replace, though, those medical record numbers with separate anonymized or confidentialized identifiers. So we take the data, we combine them, we lift off medical record numbers, we replace those medical record numbers with separate identifiers, partly because we don't want to have to deal with names or social security numbers, but also so we can go back. So when we see patterns of data for individual patients, we want to be able to go back in to that hospice's electronic medical record system. Because remember, all of these data are extracted from EMR systems at hospices around the country. We want to be able to go back remotely into that EMR system and figure out why this string of patients is missing those data. We can only do that if we have some way of tracking them down. But the linking codes, and this is the last point I'll make here, the linking codes that tell us this medical record number, this patient goes with this ID that we have, that single file that has both of those stays on each hospice's server. So there's no way that I could tell that number 12345 goes to John Smith unless I have a way of getting access to that hospice's server, which means I can't figure out who that is unless the hospice lets me know who that person is. That's useful in terms of ethical review and confidentiality, but honestly, it was really important. Again, I'm giving you some of the background story. It was also really, really important for the hospices. They really wanted to know that if these data fell into the wrong hands, nobody would be able to identify who these patients are. And there are other ways to do that, keeping the data secure on the server at Penn, which we do, but that didn't resonate with them as well as keeping that linking list on their server. That was one thing we heard, and so that's one thing that we built in. So then we merge these together and put them on the server at the University of Pennsylvania for analysis with all of the firewalls and safeguards that comes with it. So let me take you through in the next 4 or 5 slides a little bit more of the background story, and then I'll show you a research project as an example. But again, I'm trying to give you a sense of both how this came together, but also some of the concerns and interests we heard along the way. Because it really is a narrative. This isn't one of these projects where you come up with an idea and then you do it. It really was a process of interviews, of negotiation, of figuring out how we can balance Suncoast Solutions' financial interests in this, hospices' interests, and then our interests as researchers. But these are some of the principles, if you will, that we've ironed out. That we should always use existing data. So one of the things I promised them was that I would not ask hospices to collect additional data. Seems trivial, but these hospice providers really were averse to additional burden. We promised them a rapid return on initial questions. And just think about that second line for a moment. When was the last time you were able to, or I was able to ask a research question and then have preliminary results back in 6 weeks? If you're working with data that's already in place, in a data set, yeah, probably. But for primary data collection that involves going out and talking with patients, it's not impossible, but it's a challenge. But that's what these hospices wanted. They didn't want to publish paper within 6 weeks, which I think would be very, very challenging. But they wanted at least a preliminary sense of answers to some of these questions within a month and a half. And so that's what we promised them that we'd do. They also wanted research questions to hit some of these tick boxes. And probably the most important to them is they wanted a say in what those research questions were. So they wanted to be able to suggest research questions. They wanted to be able to approve or veto research questions, and they really wanted some say in how these research questions were formulated. And for many of you in the audience who are researchers, this is not totally new. I think we work with collaborators, we work with stakeholders and communities, but it was surprising to me how much of a say these hospices wanted in the process. But we were able to accommodate that, I think, in a way that is not only acceptable, but wound up being productive by creating a steering committee and developing procedures by which the steering committee would review research requests. Just in terms of ethics, as you can imagine, there's a lot of data flowing back and forth, including data about payers. And so we had to suffice it to say, we had to put a lot of safeguards in place, both in terms of data transmission and data storage, to make sure that not only were hospices comfortable, but the University of Pennsylvania, where I work, was comfortable. We also had to put together an organizational structure. And this has been fascinating to me, I think, because this is not the way I usually think as a researcher. This is really more a matter of community involvement and stakeholder issues and governance than it is in what I usually think of as being hypothesis-driven research. So this really took me, I think, out of my comfort zone. I was thinking that I would look at the data, I'd come up with a research idea, we'd write a paper. But the people we work with, the hospices, really wanted much more structure. And so we have an executive committee, which is made up of members of our participating hospices. Each one of our participating hospices contributes one member to the steering committee. Now that we have 55 hospices on board, or 60 on board, we're going to an election process, which again is not something I had thought about at all. But it's evidence of how seriously I think our hospices take this, that they really want those sorts of procedures. And then a process by which we identify potential projects. We assign project work groups, which are made up mostly of members of the hospices. So we made it clear that hospices could identify people who they would like to nominate. To give you one example, there's a requirement that came out in the United States a couple of years ago, 3 years ago now, that said that for patients who had been on a hospice for a certain period of time, they needed an official visit by a nurse practitioner or physician to document that they're still eligible for hospice. And we decided to study that, the impact that that law had on people staying in hospice. And we had a couple of hospices say, well, we have these nurse practitioners who are doing these visits. They would love to participate in this paper. They didn't have any research experience, but they knew the mechanics of what this was and how this worked. So we get many nominations of people who really don't have any research experience, but who want to be involved in the paper. I'd be happy to talk offline about how to accommodate those sorts of interests, how to involve somebody without research background in a paper that makes use of their expertise and make sure that they qualify for authorship. Has not been for me as simple as just welcoming people on board to make sure that those authorship criteria are met, but I think it's doable with a lot of work. I've alluded to this a little bit, so I'll skim through this a little bit more quickly. Ideas come in often from frontline providers within the network, sometimes from outside researchers. We just finished a paper that was suggested by somebody from Boston University. She was very interested in where people want to spend their final days, where they actually do spend their final days, and whether the growth in hospice inpatient units is shifting that. She pointed out that more and more people in hospice are dying in inpatient units, and she wanted to know, is that really consistent with patient preferences, or are hospices filling those units because they have those beds as they're building units? So I think that's coming out in BMJ supportive care. But that idea came from an outside researcher, but we've had other ideas that have come from frontline providers within the Choice Network, which is, I think, honestly, just offline, that's one of the things that I'm most proud of, that we've had physicians or nurses generally, I think, those are the ones who have originated most ideas, who have come to me and said, I see this all the time in my practice, could we study it? And we were able to take what was essentially an observation and then turn it into a paper that person then could have a role in. So we form working groups and then do the analysis and create a paper, which then is reviewed again by the steering committee. In the United States, I might ask you if you'd recognize this. There's at least one American in the audience, or at least there was. Oh, there you are. Hi. You don't recognize this, do you? I won't put you on the spot if you don't. No. It's a national park out in the west in Colorado called Costa Mesa Forest. And it's one of the most terrifying trails I think I've ever been on. It runs along the ridge at an altitude of about 11,000 feet. And for most of the ridge, and this goes on for like 2.5, 3 miles, and you're walking with a sheer drop off on either side. That's not why I showed you this picture. The reason I showed you this picture is that's often what it feels like to negotiate Choice's mission to focus on safe and effective care with all of the requests that we get. Could we study this? Could we study this? Could we study that? Our time is limited. My bandwidth is definitely limited. And so we've really tried to effectively stay on the path. We've really tried to identify those research questions and focus on them that are really going to help drive safe and effective care in hospice, and to begin to answer some of those questions that are analogous to what Primo Levi asked 100 years ago. What are 80 years ago, what are some of the ways that we could improve hospice care? And it's a challenge because there are a lot of things we don't know. And there are a lot of great ideas we get from hospices all the time. And part of running this network really has been to say, well, no, that's a great question. We might even be able to answer it given the data that we've got, but we really need to focus on things that we think will improve quality in hospice care. And the steering committee has been helpful in giving us guidance, but they've been harmful too, because they've got ideas of their own. And I'd say probably every week I get some idea from our steering committee that we need to talk about and prioritize. Authorship, don't need to go over this with you, except to say that I really did need to go over it with our steering committee. And I do need to go over it with our frontline providers who don't know what authorship requires. And this has been a constant ongoing education. Again, this is part of the background story. It's much more complicated in a way to work with people who have a lot of clinical expertise, definitely know the subject matter, have insights that I could never dream up, despite the fact I work in a hospice too. But there's some gaps in what they bring to the table, and this is one of them. Being clear about what's expected of authorship is something that we need to go over with everybody as soon as they join a project. So for the next maybe 10 minutes or so, let me spin you through one research project. Again, I wanted to give you a mix of story and what we've actually done. So as I've said, we have about 160,000 patients, 5 years of data, 14 hospices, which is increasing to 60, hopefully by the end of December. Size ranges, average daily census, between 200 and 2,000 patients. Actually, we just added another hospice that has a census of about 2,500, so that's a little bit out of date. Median length of stay has gone down in this population nationwide. Now our median length of stay for our choice network is probably about 19 days, and it's about 18 days nationwide. But about a quarter referred in the last week and about 10% in the last 24 hours. So this is still a very sick patient population. Just to walk you through how we've begun to flow research projects. It's a little bit complicated, but to give you a map of where we've tried to go. We've done some studies, which I won't show you examples of all these, but just to talk through them instead. We've had probably 10 or 12 published papers in the first 2 years, so not a huge number, but we've tried to hit most of these. We've tried to publish some papers mostly to demonstrate that our methods are valid and that we can actually get data out of electronic medical records for multiple hospices, which seems kind of straightforward, but some of the initial grants we got were really just to demonstrate that we could actually do this on a large nationwide scale. We also try to figure out what the problems and needs are that are out there. Things like where do patients want to die, where do they actually die, and where's the mix there. Inadequacy of pain management, which patient populations have their pain needs met, which ones don't. So that was also important to begin to guide where we're going. Number 3, I would love to get there, and we're just beginning to edge into that area. We're just beginning to figure out how we can connect process of care measures with outcomes, which has really been retarded, I think, a little bit because we don't have good outcome measures. At least in this data set, and arguably in hospice. There's certainly some measures out there, but in terms of things that are used widely by all hospices in the network, it was really hard to find some. And hopefully that'll change. We have some outcome measures we're starting to implement, but that's really been a barrier, I think, to identifying what effective care looks like, because we don't really know what outcomes to measure yet. Or we know, but we haven't necessarily convinced our hospices to measure them in a way that's reliable. And then I would really love at some point to get to more implementation research. So this is partly a what have we done slide, but it's also an aspirational slide. I would love to know not just what effective hospice care looks like, what best practices are, but how do you get entire teams of people to start following those best practices? And we could actually get there with this data set. Because it's a living data set, we can figure out what people are doing now. We can develop an intervention. We could figure out what people are doing a month from now or a year from now. We can figure out how we're able to change practice. So we could do this. We're just not there yet. I give you a couple of examples of papers that we've published. Just I think all these are in the last couple of months. I'd be happy to give you reprints if you're interested. But this is mostly, I won't talk about these, but this will give you a sense of kind of where we've tried to go. It's everything from predictive modeling. Can we predict which patients are likely to die soon, to evaluation of some of the case mix adjustment factors that go into measures of quality. So we've tried to, not exactly cover the waterfront, but we've tried to delve into areas of prediction, which is relatively easy given the data set that we've got, but we've also tried to get into areas of case mix adjustment, which is where we'd want to go. So far, we've developed a track record of doing some of this research. I think probably the most important achievement, that's more important than anything on here though, is our ability to get data out of multiple hospices. It seems really simple. You'd think they all use the same electronic medical record, and it has been simple relatively. I mean, it's certainly been easier than doing primary data collection, doing interviews of 160,000 patients. So with that as a reference, yeah, it's relatively easy, but it's been much harder than I would have expected. And we've also, I think, been able to develop a track record for funders, which in the United States is really important. It's almost impossible these days to get large-scale funding unless you've shown that you can already do some work. So let me talk you through in the next 10 minutes or so, and then we'll wrap up with one example. So I've already told you that patients in the US enroll in hospice very, very late. This is, I think, more the recent national data, about half in the last 18 days. That creates a lot of the challenges, as you can imagine. Patients don't get access to services except in the last days of life. Families don't get access to services. It's really difficult for hospice staff to take care of patients, often in the last days of life. And financially, it's challenging. We don't need to focus on that, but it's really, really hard for a hospice to mobilize resources to take care of patients for a couple of days. And hospices often, when they're faced with large numbers of very, very short-stay patients, lose money. So there are a couple of questions that, because this is really a burning issue for a lot of hospices, there are a couple of questions we're working on, and I wanted to show you just one as an example. It would be easier, we realized, for a hospice to take care of patients in the last days of life if that hospice were able to identify those patients who are in the last days of life. Meaning if you knew that of these 10 patients being admitted, that 3 of them, and these 3 in particular, were very, very likely to die within the next week, then you could plan accordingly, right? You could mobilize resources, you could get a nurse out to visit that patient this morning instead of this afternoon, a social worker to visit today instead of tomorrow. You could plan accordingly, and you could staff accordingly. So one thing we were curious about was whether frontline providers, mostly in this case the nurse who goes out to see that patient at the time of admission, could he or she accurately identify patients who are likely to die within a week? And if not, could we develop a statistical model that would help those providers to do a better job? Because remember, one of the things the CEOs told us is we want results fed back to us. So we want to know how well we're doing in identifying these patients, and we want some statistical model that would help us to do better. Keeping in mind, down the road, we have some other things that we're working on. This is right now in process, and then we're working on the 4th one as well, but I'll just focus in the next few slides on the first 2. So, do you have the slides in front of you? You don't, good. So what do you think? No?
Very soon. How soon is very soon?
Spoken like a true researcher. Let's say, just arbitrarily, because that's what we said in the paper, a week. Yeah, maybe. I'd like to think so, maybe not, but these are hospice nurses. They take care of patients who are near the end of life all the time. If anybody is good at this, right? They should be good at it. So here's what we did. One of the cool things, one of the disadvantages of working with electronic medical record data is not all hospices ask the same question. So in this data set, one of our hospices decided that they wanted their nurses to rate how likely they were, yes or no, a patient was to die within a week. We only had that for one hospice, but we had 5 years of data, remember. And this was a medium-sized hospice. So we had data for 9,000 patients, which isn't bad. So this is only one hospice, but we have these data for one patient. We calculated RC areas for that prediction for those 9,000 nurses. We found 2 things that are interesting. One is that their accuracy was 83%, which I'm not sure how that fits in with the answer that you were thinking in the back of your head, but I guess my quick answer is that's probably pretty good. It's probably better than most of my oncology colleagues would do, for instance, with no offense to oncologists in the room. The interesting thing to me is that although that overall accuracy isn't bad, the sensitivity was only 53%, which means that half of those patients who were going to die within a week, that nurse didn't identify. So accuracy isn't bad, but if the goal is to identify these patients who are likely to die, you ideally want to do better. So we tried building a statistical model. We, again, focused on 7-day mortality, developed it in one hospice, tested it in 2 other hospices, developed prognostic weights for variables defined by the beta coefficients in those models, which is not particularly innovative, but that's something that we've used before and that works. And then came up with a score. I'm going to skip through this in the interest of time. If you're curious about what rockets and pencils have to do with prognostic modeling, you can ask me later. But we identify a lot of variables that were significant predictors. And this is the other story piece of working on modeling. As a researcher, I would have built a model with 12 variables in it because it had the best RRC area, it had the best information criteria result, so it was the best model. But what our partners in these hospices told me is, that's not useful. Like, don't give me a prognostic model in which I need to enter 12 different individual bits of data. If you can pull it automatically from the electronic medical record system, fine, but if you're not there yet, give me a model that's not as good, but not bad, which is easy. And that turns out to be the PPS score, whether somebody's admitted from a hospital versus other location, and gender. And I'll show you the results in a minute. But so clinicians, sensitivity, overall accuracy. Sensitivity was considerably better, not perfect, but not bad. And overall accuracy was about 90%, which is about as good as you can get with a model. And there's certainly some models out there that have overall accuracies of 91, 92. But there's a great review in Archives of Internal Medicine, I want to say it was like 2 years ago, that reviewed a lot of prognostic models and said that basically if you can get a model with an accuracy of 0.9 or so, you're really in good shape. And that's certainly been my experience of a lot of models in palliative care. So this is not perfect, but it's not bad. And again, we were able to achieve that with only 3 variables. And just for reference, I think their 12 variable model, the overall accuracy was 90 or 91. So not that much better. So we built a model that people thought was usable. This is what this looks like graphically. 3 lines here, prognostic index along the y-axis. Sorry, x-axis, still a little bit jet lagged. And then proportion of people dying within 7 days on the y-axis. There are a couple of points here. One is that these 2 lines, which are a predictive model and what actually happens, are pretty similar. They're not totally superimposed, but they're not bad. I mean, they're close. But both of these lines are considerably higher than what nurses told us, which is consistent with what I showed you before. That nurses overall, their accuracy wasn't bad, but consistently across different patient categories underestimated the likelihood that somebody was going to die within 7 days. Broader testing, we haven't published this yet, but I'm trying to figure out whether and how and when. What's really interesting is that when we start applying this model, which actually becomes fairly easy once we have it, because we have plenty of other hospices data, the accuracy range is a little bit higher in some hospices, but it's considerably lower in others. And that's not that surprising. Many of us who have developed prognostic models know that when you develop it, it looks great, and then other people try to use it, and they have slightly different experiences. Sometimes they call us or email and say, well, your model isn't working for my patient population. That's not that new. What's new here is because we've got all the data, we can begin to figure out why it's not working. Part of the reason why is that model accuracy varies among diagnoses. So much more accurate for cancer, say, than it is for stroke. And so a hospice that has fewer cancer patients, more patients with stroke, is going to have a lower overall accuracy, for instance. Also different patient populations, which are going to affect accuracy. Also staff training. So the Palliative Performance Scale, as many of you know, is at least to some degree in the eye of the beholder. And for staff who have regular audits, who have regular reviews on how to rate PPS scores, my guess is that those are going to be more accurate. And we know, for instance, that some hospices do provide that training to nurses and others don't. And we're in the process of trying to figure out whether those hospices that provide that kind of training have better predictive values based on PPS scores. So again, getting back to the story that I was telling you before, part of the pitch for this study and part of the pitch for the value of these studies are intertwined, because we had to convince hospice CEOs to sign on to the study in the first place. It's partly care planning. It's partly telling patients or families what you think the prognosis is so you can plan care appropriately, but also information for families. So the daughter in California could come out to visit her grandfather now rather than waiting until final exams are over. one of the surprising things to me, and this has been a learning experience all along the way, but it's also this one, that a lot of our hospice CEOs said, this is really useful. Yeah, for clinical purposes, we get that, but we really want to know about it because of staffing. We really want to know if all of a sudden we have an increased number of patients who are likely to die within a week, because I didn't show you the data, but these numbers fluctuate, just random fluctuations, or fluctuations that are driven by increased partnership with hospitals. That proportion of patients who die within a week will range anywhere from 20 to 30% for a hospice over the course of a couple of months. And that's actually a lot. I mean, imagine that increases by relatively 50%. That means a whole lot more staffing. You're taking care of a lot more patients near the end of life, and CEOs want to know about that. So we're in the process now of developing a field within the electronic medical record system that will put up a flag if patients meet criteria of being more than 75% likely to die within a week. And the interesting thing about that flag is the clinicians really want it and the CEOs really want it. Like, this is one of these things that everybody identifies as being important. In terms of next steps and where we want to go, we're really trying to focus on these sorts of questions that have a really quick turnaround time. And so far, with a couple of exceptions, really the one outlier, I think, to that 3 to 4 month idea to paper goal was due to maternity leave. So that's one of those things that I can't do, not mine, but somebody else's. But in general, I think we've been able to adhere to that, and that's been our goal. And again, it's something that hospices really, really want. They really want to see results turning into research papers quickly. Thanks to a couple of grant funders for supporting this work. And this is probably the slide I'll leave you with, because it's maybe a good jumping off point for discussion. That'll save us 10 minutes for questions. We're really trying to both push research results up into valid, reliable data, push those results back to hospices in a way that has a fast enough cycle so that people pay attention. I know that sounds silly, but if you talk about a research project and you're a busy hospice provider and then a year later you get those results, it's really hard to maintain attention. So we're really trying to maintain a cycle with a loop of 1 or 2 months of getting data, providing results, getting back to hospices, and then to begin to think about implementation. I'd be happy to talk offline about some of the QI projects that we're implementing, but this really is a goal for us.